Hello, from here we will discuss the relationship between pulse field ablation and hypertrophic cardiomyopathy. I'm a Japanese cardiologist. I'm known as Ushi-sensei, whereas Ushi means cow in Japanese. On this channel, we will be explaining topics related to cardiology. In this video, I will summarize the paper titled Pulse field versus thermal catheter ablation of atrial fibrillation in patients with hypertrophic cardiomyopathy. Atrial fibrillation (AF) is common in hypertrophic cardiomyopathy (HCM) and is linked to poor tolerance, hospitalization, and heart failure, making rhythm control strategies preferable. Catheter ablation is guideline recommended when antiarrhythmic drugs fail, but outcomes in HCM are worse than in non-HCM patients, with higher recurrence, need for redo procedures, and complications. Pulse field ablation (PFA) may offer advantages over thermal ablation in HCM, effectively in fibrotic thick atrium, enabling extrapulmonary vein ablation efficiently, and potentially reducing procedure time and complications. This is a retrospective study of consecutive HCM patients undergoing AF ablation at 3 French and Swiss centers between 2016 and 2024. HCM defined per 2023 ESC guidelines based on clinical, genetic, and imaging data collected. Both procedures aimed for pulmonary vein isolation. Extra PV ablation performed at operator discretion. Primary endpoints sustained atrial arrhythmia recurrence at 20 months and major procedure complications. This figure shows the annual number of first AF ablation procedures in patients with hypertrophic cardiomyopathy from 2016 to 2023. We can see a gradual rise over time, with a sharp increase after 2021, corresponding to the introduction of pulse field ablation. This trend suggests growing adoption of AF ablation in HCM, possibly due to improved safety and evolving guidelines. This table compares demographic and comorbidity profiles between thermal and PFA groups. There were no major differences in age, sex, and more comorbidities. The only notable difference was higher indexed left atrial volume in the PFA group. The genetic mutation profile was similar across groups. This table details F-type symptom severity, prior treatments, and atrial size. Persistent F was present in over half of patients. The PFA group had significantly larger left atrial volumes, and the thermal group had more patients on sotagliflozin before ablation. Symptom burden was generally high, reflecting advanced disease. Here, the curves are stratified by ablation type. PFA shows high freedom from recurrence compared with thermal ablation, with a statistically significant difference. On panel C, these curves evaluate the effect of additional extra PV ablation. In the thermal group, extra PV ablation was associated with worse outcome. In contrast, in the PFA group, extra PV ablation did not negatively impact recurrence rates, suggesting a difference in lesion durability between energy sources. This table presents the Cox regression analysis. In multivariable analysis, PFA was the only factor significantly associated with lower recurrence risk compared with thermal ablation. Extra PV ablation increases recurrence risk in the thermal group, but not in the PFA group. In conclusion, in patients with HCM and AF, PFA seems to be associated with better safety and efficacy outcomes than thermal ablation. Thank you so much for watching until the end. If you find this helpful, please give it a thumbs up and subscribe to the channel. Bye.